MENA Organization for Rare Diseases. I want to thank everyone for taking the time to join and be part of the conversation during these 3 days. I'm Karen Kaadi. I will be the host for this session. I'm a neurodiversity writer and advocate and the founder of People of the Derby Nation store, and I am very pleased to announce the moderator for this session, Dr. Walid Kaplan, Department Chairman and Consultant Pediatric Endocrinology, Dhabi Hospital. Thank you.
Thank you. Good morning. So we're going to start with the session. I think more people will be showing up, but we need to stick to the time. So it is my pleasure and actually honor to introduce the group of speakers for today. We're going to start with Dr. Mohamed Sulaiman, who is a consultant pediatric cardiologist, whom I had the pleasure to work with for several years. Very pleasant person. He's assistant professor of clinical pediatric at Columbia University. He's also the director and co-founder of the KidsHeart, very well-known center across UAE, and he's going to talk to us about case scenario on cardiomyopathy and arrhythmia.
Thank you, Dr. Kaplan. I don't know who decided to put Dr. Kaplan as my moderator. Dr. Kaplan for me is like a godfather. I have full respect for him, and whatever he tells me, I will do. That's my style. So, thank you for everyone to come this early in the morning. I am going to wear a little bit different hat today, which is like more like a genetic person, which I'm not really a genetic person, but we'll try to talk about how a genetic of cardiomyopathy will evolve for our life. I have no disclosure for you, so we're going to talk about the objective. We'll do a genetic review for hypertrophic cardiomyopathy, muscular dystrophy, and then we'll talk a little bit about primordial metabolism, and we'll see if we can do any recognition for some symptoms. So this is the big picture of cardiomyopathy with different types. As you see here, this is the normal, what we call normal. This is the compaction, which is increase in the spongy portion of the myocardium, mainly in the left part. And this is the hypertrophic cardiomyopathy, and this is the dilated cardiomyopathy. Here, this is the big umbrella of cardiomyopathy. This is the way also how we think about it. Different come either to familial or genetic, or non-familial and genetic. And from here we start with the classification of hypertrophic cardiomyopathy. So from the genetic perspective, as you see here, one gene can cause different cardiomyopathy type, and also some cardiomyopathy will be done by different genetic codes. Multiple modes of inheritance, autosomal dominant, recessive, X-linked, and mitochondrial, and others. Variable age of the onset, variable penetration, which somebody will be affected with the same gene, somebody else will not be affected with that gene. So, in general, when we test for cardiomyopathy from the genetic point of view, we can detect about 40% across the whole number. But if we focus more in the cardiomyopathy, we could, hypertrophic cardiomyopathy, we can reach up to 60% of detection rate of the genetic cause. So why do we need to genetic testing of these children or these patients? First of all, it could change our management. As if you have muscular dystrophy, we'll decide what you're going to do next for the patient. It will also, the metabolic cardiomyopathy, you may have some enzyme therapy, so we need to know if this is part of it. And alter the prognosis as well. Some cardiomyopathy, specifically hypertrophic, may have increased risk of sudden cardiac death, and may affect even the heart transplant to decide if this patient will be a good candidate for heart transplant or not, and influence also the risk stratification for other family members and so on, as well as for the patient. So genetic assessment, there is 3 pillars that we have to look when we talk about cardiomyopathy in general: the cardiac phenotype, the extracardiac issues, and the family history. So this is a very important for us to recognize, and each one of them will yield very important information for us. So for genetic assessment, for cardiotype, remember, this cardiotype may change. It's not going to stay still. So a patient with hypertrophic cardiomyopathy might end up with dilated cardiomyopathy and so on. Extracardiac manifestation, some cardiomyopathy will be associated with extracardiac manifestation, and this is very important for us to recognize when we check the patient and to understand if he has any problem related to weight, related to metabolic disorder, hypotonia, or weight gain, feeding difficulties, dysmorphic feature, and so on. And then we have to look at the pattern of the genetic process. Hypertrophic cardiomyopathy, we focus more on it in this presentation because it's more linked to genetic issues than the other types. So we have the familial or the genetic portion, and it's here in a different format. So from all ages, if we look at the familial hypertrophic cardiomyopathy, at least 70% sarcomeric, and sarcomeric and the others about 30%. But across the whole pediatric population, which we look at a younger age, I believe the difference in the number between 70% here and 25% here for each portion is due to we lose some of this patient down the road, or this patient will show at a later stage of their life. So hypertrophic cardiomyopathy, as we said, it's about 25 each for pediatric population. So sarcomeric, syndromic, neuromuscular, and metabolic. There is two main genes for the sarcomeric, which is MYBPC3 and MYH7, and they contribute to about 80% of hypertrophic cardiomyopathy. So these two genes are very important when we test for them. They are usually autosomal dominant, so when we consult the family, we'll tell them expect the next generation, at least half of them, male and female, will be affected. And most of the time, diagnosed as adolescent age, and this is a big, huge diagnosis for us. You know, child, usually athlete person, going to school, run, and do different things, and for some reason, either due to some symptoms or just sometimes the evaluation for participation in a specific sport, and then you diagnose them with hypertrophic cardiomyopathy, and that's a big, huge issue to the child. Of course, we have to remember that these genes also can cause also other type of cardiomyopathy. So, do we really need to do genetic testing? The answer is yes. So this is a class 1, and it's recommended for any patient with established clinical diagnosis, and that's key. You cannot just come to me for whatever reason and I'll say I'm going to test your family for hypertrophic cardiomyopathy or for genetic. You have to have a specific reason for them, either clinical or history or some other reason. There is different type, but we most of the time will do cardiomyopathy panel, which will identify the exact cause. You can do also a whole sequence if you decide there's not much different in the price. So this is, example of a question for us, like 11 years old female, and have a 9-year-old brother with her 9-year-old brother who come for evaluation for hypertrophic cardiomyopathy. Their uncle has a defibrillator, and he also was diagnosed with hypertrophic cardiomyopathy. Both children are asymptomatic, so they just was referred because they're uncle, and have EKG normal and echocardiography normal. So what you should do, what kind of test? Just test the female, test the male, test the mother, no need for test, or test all or none. Any suggestion from the audience?
Mother.
You want to test the mother. That's a correct answer because she's the closest person to the uncle. So that's his sister. So that person you want to evaluate. If I have access to the uncle, I will start to identify the gene for the uncle, and then I will go to the next person, which is the sister and the brother of that. So let's say, the mother has some gene, but she doesn't have any symptoms. Her heart is still fine, but she has the genetic material. What should you do next? Test the children, both of them, right? So we will test the children. So If their test is negative, what should you do? It's okay to keep following them for cardiology, do echo yearly or no? No. So we can graduate, and that's absolutely good. So this is the pathway that we can use for, when we decide how we deal with patients with family history of cardiomyopathy from the genetic testing. Anybody know who's this person? I think you all know because I already described every single thing you could imagine. I wish any child or patient will come to us with all of this description. So as you see, there is some facial structure, there is all of this kind of different things that this patient, mode of inheritance, this is the gene related to him or to her, and there is a normal karyotype. So normal karyotype does not exclude other genetic causes. He has pulmonary stenosis and hypertrophic cardiomyopathy. Of course, he may have, if you test in this area, you may have clotting issues, and he has increased risk. This is not the treatment. This is the treatment only from the height point of view. But from the cardiac point of view, we have a big problem. Anybody know who's this patient? No, thank you. So this is his ECG, and this is for us, really, sometimes this Noonan syndrome, they mislead us, and we don't think they may have some facial structure and so on. But if we do the ECG for them, it's very characteristic. You have left and right ventricular hypertrophy at this age as a neonate. And this patient usually, important part of cause of hypertrophic cardiomyopathy, and most likely they will present at an infancy or at later age, and they have higher mortality, and management will be, of course, complicated by the cardiac problem. So this patient may end up by needing for surgery for their pulmonary arteries and so on. So 14 years old, chair-bound. It's a specific picture for any patient that as soon as I tell you, give you this idea and I give you the related cardiomyopathy, that patient would be which one? Duchenne. So this patient is a classic picture of Duchenne syndrome. This is the way that, we're going to talk about this dystrophinopathy for this patient. So usually most of them is linked and related to the genotype relating to the dystrophin, and usually will result in related cardiomyopathy, and there is different variants of genetic structure for this patient and variable presentation. So Duchenne will start earlier in life, while Becker will show up later in life, but these still have the same pathology. So muscle disease usually is a very important portion to identify this patient, because the heart is, in the end of the day, it's a muscle, so we can look at different things. High CK is a very important. If you test a patient with high CK, you have to think about the next step for them. And if you have high CK and muscle disease, it should promote you to the next step, which is identifying their cardiac issue as well. Again, there is different spectrum of progress, so from mild, very mild to severe. Duchenne stand here in the end of the day. This is, I think you understand, this is the Gowers sign, that when the patient basically uses his limb to stand up, usually start around 4 years or 5 years and so on. It will show itself, and this is bigger, different manifestation for the patient. Usually Becker will show itself at a later stage. Of course, Duchenne patient may, die by their 20s, or maybe very rarely will last until their 30s. Very, very rare. Other different type of dystrophy, memory Dreyfus, which is basically mutation in a specific gene, as you see it in here. It's mild skeletal involvement, but the cardiac problem is a very, very much common and very important, because it could cause sudden cardiac death. So usually they have related or hypertrophic, but this patient are very important for us to identify, as they might have caused sudden due to, of course, due to arrhythmia. So this patient usually will have some contraction in their muscle, in their Achilles, and they are usually very specific for that. Limb girdle also could be autosomal dominant or autosomal recessive, and usually either in child or in adulthood, and the mutation in this specific gene. And usually this patient, again, the important part about it is this is the gene that involved, and you could have a risk of sudden cardiac death due to arrhythmia. So the important about muscular dystrophy, important to identify, you have to identify their skeletal muscle as they will be part of the issue that we need to, so they will have scoliosis, hypoventilation, that will complicate your management for this patient. And then some gene linked to sudden cardiac death and some specific concern for us to decide what to do for this patient.
2 minutes, Dr. Mohammed.
How many?
2 minutes.
Friedreich ataxia will present with ataxia initially, but the heart might show at later stage of the life. This is just diagnosis by phenotype. As you see, there's variable things. Most of them will have extracardiac, except the hypertrophic sarcomeric will not have much. This is by the mode of inheritance. You can see different type of inheritance of the patients. This is my last topic I will talk about. So inborn error metabolism, about 5% will have cardiomyopathy of them. However, usually they are autosomal dominant, recessive, and usually they will have hypertrophic cardiomyopathy. There is one patient, very, very famous for us. This is the different type. There's many of them that we don't have the time to discuss. But this is the one that 4 months old. Okay, dysmorphic, non-dysmorphic, and this is a key point for us with feeding difficulties. Baby is at 3rd percentile, non-dysmorphic, tachypneic, tachycardiac, and hypotonic. He has large systolic murmur, echo show, right ventricular hypertrophy. Our parents are second cousin. So what will be the diagnosis for this patient? So key for this patient, you know, we think it was as an example for Noonan syndrome, but Noonan syndrome, they usually will have dysmorphic feature. So we move out of the morphic and hypertrophic usually for this age. If we add, this is different. Muscular dystrophy will not show at this time. Probably this one could be, but not as this one has dysmorphic feature, and this is the key of the answer, inborn error metabolism. And this is his ECG. If you see this ECG once in your life, you should remember it for life. And if you are a general pediatrician or whatever your job, you should say this patient is. Anybody from the back? Pompe disease. So Pompe disease is a very important to diagnose early. We usually diagnose them even prenatally by doing fetal echocardiography. And this patient, we start even enzyme therapy. This is the important thing about all of this inborn error metabolism, because there is some of the good solution for them, regardless of the long-term outcome. I know, Doctor, this is just a kind of review for inborn error metabolism, and this is another way diagnosed by phenotype. This is a review how you look at phenotype. This is the way we approach patient with hypertrophic cardiomyopathy. This is a pathway. Again, physical exam, some test, and then you go down the road to decide. Last slide, hypertrophic outcome. As you see here, inborn error metabolism, we lose most of them in a very short time of their life. Maybe half of them by 8 years already, we lost them. Other time, you might lose some numbers, 10%, 20%, and so on. And save the date. This is our next KidsHeart conference. It will be in Abu Dhabi, so anybody who wants to register, you are welcome, and thank you very much. Did I do good?
Thank you. No, you did very well.
Thank
you. Sorry to rush in for the time.
Do I owe you anything?
Again, or you want this mic is working, right?
Yes.
Have you tested? So somebody wanted to ask a question from the audience, right? You have a question? It's been answered, okay. So my question is about the limitation of genetic testing in UAE. From my experience as a pediatric endocrinologist, even if I need to do a simple genetic test to diagnose a Turner syndrome or something like that, it is not covered, neither for local patients nor for non-local. So how do you deal with this from a practical point of view when you say it should be done for cardiomyopathy?
Yes. It's a very much a dilemma for us when we visit every day almost in our clinic. Now, I give the parents, let's say if there is a family history of hypertrophic cardiomyopathy, and the test will cost them about 5,000 dirham. So this is a general roughly estimate. I'll tell them either you pay this 5,000 and you live the rest of your life fine, or I probably will need to follow your child throughout until I see development and growth development. So the insurance company will end up by paying more money, but by checking the child once a year or something like that. So, but that's how it is for now, unfortunately. There is a project that we are working with University of Emirate University, which they provide a free testing, but that usually takes a very long time, and it's not committed to specific, but they do it part of research, and they do it for free. So some of these parents, I send them for this kind of testing, but the outcome may take about 6 months to 1 year to get the result. And they may look for different things more than what you are. I'm looking for hypertrophy, and they are looking for all of these genetic materials.
Thank you so much. Any other question? Okay. So, on behalf of Dr. Khattab and the organizing committee, I would like to present this certificate for Dr. Sulaiman.